Welcome to another Wednesday session. This is a combined session with Orthopaedic Research UK, OR UK, and the FRCS Management Group. We are very happy today to present Mr. Zuhair Nawaz. He's a revision and periprosthetic specialist interest in Frimley Park. He's had opportunity to work and gain experience in several tertiary arthroplasty units, both in the UK and abroad, and has had completed an international trauma fellowship in Calgary. He's completed the European ESSKA knee fellowship in Italy, and he graduated from Imperial College in London and completed his basic surgical training both in London and a registrar training in Thames London rotation. He has an excellent background in teaching, and I've taught previously on these courses, including Wrightington and St. Peter's FRCS. And that's where I remember meeting you, Mr. Nawaz. I was at the Wrightington course. You were amazing. Thank you. He also has an avid interest in research and multiple international presentations and several publications, including the world's largest cohort knee cartilage transplant. Mr. Nawaz is today going to give us a presentation on clinical-based basic science. Those of you who know me know that I consider this the most important topic in the entire syllabus because it's the basis of our entire syllabus. So I'm really looking forward to today's talk. We'll start with the talk from Mr. Nawaz, then we'll have invited questions, and then we'll have example questions from his registrar, Arpanda Gurwal, who recently passed the exam. And we'll, after at 8:35, we'll close the session there and start our Wednesday evening Viva session, which will be the unrecorded portion of this teaching session today. Without further ado, Mr. Nawaz, really looking forward to hearing your talk. Thank you so much.
Right. Hello, everyone. As Shawan said, this is probably one of the most important topics in the exam. Almost certainly every single Viva station somehow relates back to basic science. So I've kind of based this lecture on a few clinical cases, which we'll go through. We'll cover some of the kind of standard kind of basic science that goes around it. So it's going to be slightly lecture based, but it'll be based on important things that you need to know and be able to discuss in the exam. Okay, so it's not moving. What's that not working? Sorry. Right, so we're going to talk about fracture healing and non-union. It's basically the commonest question you can get in the exam. In some way or another, you're going to get a bit of failed metalwork, a fracture non-union. It is classic. So 1 out of 2 candidates will get something along these lines. So the approach to the question is talking about the fracture itself, the soft tissue envelope, the metalwork, the alignment, and a little bit about the host. But actually, it's this bit down here, the metalwork bit, and the fracture personality, where they want you to bring your basic science in. What type of implant would you use? How do you deal with the defect or the non-union? And why do you think the fracture's failed or hasn't gone on to healing? So this bit is very much a basic science question. So it's very, very common in trauma to talk about basic science. And it is important that you understand trauma basic science, okay? So this is my favorite slide. Anyone who's been taught by me always gets this slide. So this is your classic example of a fracture with a plate failure, and it is important that in the exam you highlight the important things. Okay, so the priority here is to see that this is a very comminuted fracture, and the most important word in the exam probably is to say segmental. You have a fracture line here, you have a fracture line here, so this is a segmental fracture, which immediately tells the examiner you understand that this is a high energy injury. This immediately then also implies that we're talking about the soft tissue, the blood supply. You then comment on the lateral view, where you could talk about the bone looking sclerotic. So again, one of my cardinal rules in the exam is if you ever see metalwork in the exam, you always have to say the word, could this be infected, okay? With the metalwork, we then talk about the metalwork. So in this situation, they've used what is called a DCS plate, so a screw device, with what is a non-locking plate, and we're going to go through what we look at when we're talking about plate fixation. So what mode is this plate being used in? So most people would say that this plate's being used in a bridging mode, which is what most people say. Now, it is important to understand that when we're bridging, the idea is that we're essentially creating an internal X-fix, aren't we? So the idea is that the screws take the load, it then bypasses the plate, and then it comes back down through the DCS screw. Now, this is a non-locking plate. So in effect, this cannot bridge the fracture. So this is what we call a load sharing device. So this is sharing the load with the fracture. This is not a load bearing device, which is your typical bridging plate. It's a load bearing device to start with, and then as the fracture heals, it gradually becomes a load sharing device. Now, if we imagine what this plate is doing in the first 48 hours of the patient standing up, you can imagine that that plate is essentially taking the entire load, and those screws are moving within the plate. So it's important to understand that when you're using a bridging plate, a bridging mode, we have to use locking plates, okay? So this in effect is a spanning plate. This is a weight bearing plate, and it's sharing it with a fracture. So we're going to come back to why that's important. So in the exam, parent strain theory comes up a lot in the fracture. Okay, so this is this imaginary curve that exists. No one knows what these values are, except we know it's based around 2%. What we know is parent strain theory looks at strain. So that is the change in length over the original length. Okay, so what that means is if there's lots and lots of movement, which is this area down here of the curve, I hope you can see my arrow, then that basically means that there is going to be so much movement at the fracture site that you are not going to get union, and you're going to get fibrous tissue or granulation tissue, depending on how much movement there is at the fracture site. Whereas if we go right to the other end of the curve, and this is probably what we see more often these days, but we're much more understanding of that, is that if we make it too stiff, i.e. the change of length is so minor, so little that the implant is so stiff that actually there is no ability for the fracture to unite either. But no one knows what this little figure is right down here. What we know is we want about 2% of strain, around 2%. Okay, so that's what we're aiming for. So in the exam, when we're talking about that plate where we just saw, what we want to know is how much movement is happening at that fracture site. Okay, and then similarly, if we look at my next slide, which is going to come up, this is the same plate with a different fracture. And you can clearly see that the amount of movement that you expect with construct 1, construct 2, construct 3, and construct 4 would be completely different. And again, think of it like an external fixator. How much movement are you going to get? Okay, so you need to think about how many screws you're going to put in, what type of device you're going to use when you're talking about metalwork, and the fracture pattern. So a simple transverse fracture, do you actually need to bridge it? The answer is probably not. You just need compression. Whereas if you've got something like this, where you don't want the weight going through it, then you want a bridging mode. So therefore, you need to then think about how much strain or how much movement you want at your fracture. So if this was an extremely comminuted fracture compared to say something like this over here, then you would probably end up putting more screws in here to try and hold it in the kind of 2% range. Because if you just did 2 screws far away, 2 screws far away, then the amount of movement you'd have in fracture would be quite significant. Whereas in a fracture like this, actually 2 screws either side would actually be quite reasonable. So the idea being is that when you're doing these fixations, the idea is to try and work out the right amount of movement of the fracture. And that's partly experience of understanding, but there is lots of evidence to say we talk about the near-far constructs, talking about screws far away and screws nearby. And we'll come back to that because that's something else that's quite important. So this is what I'm talking about when I talk about spanning plate. What is this plate doing? Okay, so this is a spanning plate that's spanning a comminuted wrist joint. It's not being used in bridging mode. It's just jacking out the joint and almost using ligamentotaxis to hold the fracture in right place. But if the patient tries to move this arm or wrist, then it's actually going to start moving at the screw plate interface rather than a locking plate where you get this, again, this diagram of the force coming up, going through the screw, going across the plate, bypassing the fracture and then back through the bone, okay? So it's an important concept when you're talking about bridging. So again, the reason behind the bridging and the locking screw is that failure requires a significant failure of one side of the entire construct rather than potentially one or two screws. So that's why we're now going to periarticular plates are all locking plates near the joint surface, because they get much more hold. And then at the top end, we're then encouraged to use non-locking to essentially get the plate on, and then locking to basically provide that bridging mode, okay? So the movement in a locking construct has to be with the whole plate. The whole plate has to move in unity. Whereas in a non-locking construct, the movement occurs between the screw head and the plate, okay? So when we're talking about that, then we need to basically go, right, we're happy using bridging plates. We understand the concept of strain. We understand that we need a bit of movement for our fracture to heal, and we need that movement to be enough that we don't get a non-union, i.e. too stiff. So here again, this diagram is designed in a similar way to talk about where do you put your screws? Do you put them close? And in this construct, you can see 4 screws on either side, very, very close to fracture. So you can see the amount of distance there and the amount of movement you're going to achieve is going to be almost negligible, okay? It's going to be tiny. Whereas when you have this scenario, the further the screws away, the more movement you're going to achieve at the fracture. And from your point of view, you're going to get more a chance of union. This is where the concept of working length also comes in, because when we're talking about working length, most people talk about working length of a nail, and they're very happy to talk about a working length of a nail because they say it's from the diaphysis to the next screw on the other side of the fracture. That's what's doing the work. So similarly in a plate, how much of the plate is doing the work? So think of a plate as a lever. And similarly here, if you've only got a centimetre's worth of plate doing all the work, that is an extremely stiff construct. The amount of force required to bend that bit of plate when you've got so much fixation versus that is very different. So working length helps with your strain environment. So that's again something to be aware of. And these are the concepts that they will ask you in the exam. So again, locking plate, look at it as an X-fix. So when you look at this construct, if you put 2 X-fix pins relatively far away with a bar, is that a stable construct? Yes, it is. If it's close enough to the fracture that it doesn't wobble, then you've got a good stable construct that you can put weight through and it will work. In this scenario, you've got a standard transverse fracture and you've essentially put 4 X-fix pins in and 4 X-fix pins in on the other side, and you've basically put the rod right across and there's very little movement. And again, that is just far too stiff for the fracture to ever heal. So always think as a bridging plate as a X-fix device, a bit like here. So again, those pins are really important. So you look at this construct, sorry, I couldn't find a picture of someone putting 2 X-fix pins really close, but 2 screws right next to the fracture, 2 screws right next to the fracture, the movement at this site is almost negligible. Whereas if you have a construct like this, you've got a much better strain environment, which is balanced with a long beam that has a working length here, and these bits of the plate are pretty rigid. So you've got a nice big construct, okay? And again, the concept of how stable is this X-fix with 2 pins here and 1 pin here? The chances are this is a very unstable construct. So if you put a plate in a similar fashion, would that be sufficient? And the answer is no, it wouldn't. Okay, so we then talk about the concept of what we call on-axis and off-axis fixation. So people are used to this. The whole idea is with a DHS or a nail, you put the plate or you put the device as close or shorten the lever arm as best as you can when there's torque involved. So with any comminuted fracture, where you're going to bridge, there's essentially going to be a bending force. Therefore, there's a varus or a valgus force applied to the device. Therefore, from your point of view, the plate is best at resisting that with the shortest lever arm. Okay, so in the concept of a proximal femur, it's very simple. If you've got a subtrop fracture, and you put a DHS in, there is much more torque and the lever arm is much bigger because the plate is on the lateral aspect of the femur. Whereas when you put a nail in, it's in the intramedullary cavity, and therefore the lever arm is much shorter. Therefore, it's designed to resist torque or rotation. So again, my concept of the seesaw, you've got your fulcrum, you've got your lever arm, and your force being applied to the end of the beam. So the closer you can move that fulcrum over to where the load is being applied, the more stable and more resistant that is. Now, with a nail, it's a very simple concept to understand. With a plate, people need to understand that we also have off-axis fixation. So when we plate a femur, and I promise you this isn't one of mine, but when we plate a femur, we're actually plating it in a biomechanically disadvantaged position because we plate laterally. The weight-bearing axis of a femur is actually through the medial side. So the best place to put a plate, like on this diagram over here, is to put it medially. But the reason we don't go there is obviously the adductor canal and the femoral and all the blood vessels that occur around here. But actually, biomechanically, a medial plate is much more in favor than a lateral plate. So the minute we put a lateral distal femur plate, we are essentially creating a bending moment because the plate is over here, off the axis, okay? So one of the classic examples of an on-axis fixation is the nail, but that actually is still off-axis to a degree. So what we actually describe as pure on-axis fixation is a Lizaroff frame, because the wires cross through the center of the bone, and when you load the frame, the force is applied down the weight-bearing axis of a Lizaroff frame. So any of you that have done a Lizaroff frame will understand the concept of getting the frame to be on the mechanical alignment of the bone, not along the anatomical alignment of the bone. It's all about making sure that those wires are on the mechanical axis. And that's why a Lizaroff frame is so good at getting fractures to heal. If you have on-axis fixation, you have anatomical reduction, and you get good stability and strain environment across your fracture, you will get your fracture to heal. And those are all the concepts that your complex surgeons that do non-union surgery will use to decide how they fix a non-union or a malunion. So back to this fracture. We talk about the fracture personality. So in the exam, we talk about it's comminuted. The fracture is over a large zone of injury, high energy fracture pattern because it's segmental. We have to query whether it might have been open at the beginning, and we have to query whether the bone is dead, because if you look at that lateral view, you can certainly see that there's sclerotic bone there. We talk about the soft tissue envelope. You must always comment on any fracture when you see that. So it's high energy, so we're worried that there's lots of soft tissue stripping. When we get to the metalwork, we comment on the metal that was used. So what mode is what the examiners are interested in. And you can look at that by being able to recognize whether it's a locking or a non-locking device or the screws used. We're talking about the bridging mode or what mode the plate's been used at, the working length, and then whether it's an off-axis fixation and whether the implant has reduced the fracture and restored the mechanical alignment, which is the most important thing in anything that heals. And then obviously at the bottom is host, which in the exam is obviously less important, even though you need to mention it. The exam is centered all over this part of the discussion. One of the things that broken metalwork always generates is the vibrant fatigue failure. So fatigue failure, the definition you must learn, okay? So cyclical loading, which eventually leads to failure of the implant, which occurs, and this is the most important statement, in a single sub-threshold load or a physiological load. So that basically means that the plate is designed to take a significant amount of load, and the plate will break at a certain load with one load. That's called our ultimate tensile strength. We get a point on the plate where if you load it below that limit, it doesn't matter how many cycles you do, the plate will not break. So that's our endurance limit. So typically we talk about this curve. Now this curve is really important to understand, so you guys will understand it. So on this axis down here, we're talking about the number of cycles. It's a logarithmic scale. So from a testing perspective, companies use 10 to the million as their endurance limit. So if you load at this amount of newtons per meter or stress for this many cycles, beyond that point, the plate will never break, okay? Whereas this red line demonstrates a single cycle where the plate breaks immediately. So that's our ultimate tensile strength. So that's the one single point, one load with one amount of load, and it breaks instantly. All plates that we use in fractures work in zone A, okay? Because essentially, eventually, if the fracture doesn't heal, the metalwork will fail, okay? So the idea is that we want our plate not to be working over here where this star is, but we want to be working down here. So the idea is that we get as many cycles before the plate breaks. So that's our race between union and the plate breaking. Now we achieve this by reducing the amount of load going through the plate. And we achieve that by getting proper anatomical alignment, proper reduction, getting strain environment right, and therefore the idea being that we get more cycles, so we get more time for the fracture to heal. So the SN curve is really important. Now, this curve suggests that at X amount of load, after say 20,000 cycles, if we load it at that much, then the plate will fail. We now know with fatigue failure that actually what actually happens when you draw this curve is that it fails at a much lower load down here around this point. So it fails after 3 months. The patient's only had 10,000 cycles, but the plate has failed well before the curve. Now, the reason for that is, number one, we're putting a lot more load through it than the plate was designed to do it. But actually what also is happening is that the plate is deforming, okay? So just before a plate breaks, you will always see that the plate starts to bend or deform. Now that means that this curve that we're looking at is what the plate should do if there's no deformity to the plate. But actually, as the plate starts to bend, you start to get something called necking, where the plate starts to thin. So a bit like a paper clip. When you bend the paperclip continuously, what you'll see is the point of most movement, the two sides of the metal start to narrow and thin out, and then suddenly they give. Now, on that curve, what actually happens is it's a single load and the plate has failed. So this curve that we drew originally is what the plate would do if there was no deformity to the plate. But actually, as the plate is bending and necking, the curve is moving down and down and down and down to the point where this load suddenly comes into what we call physiological load. So the patient doesn't fall off the building for the plate to break, because that will be this curve over here. What happens is the patient just walks and suddenly takes one step off the curb and the plate snaps. Okay, so essentially the curve for that plate has moved down. So this is a curve for the plate as it comes out of the packet. And this is the curve that's occurring as the plate starts to bend and neck, which is why you get a single episode of ultimate tensile strength where it fails. It's a hard concept to understand, but I hope everyone understands that. It comes up in the exam a lot. Right, case number 2. How am I doing time-wise? 5 to 8, okay. We'll do this one. So that was trauma. Again, a very classical case. Most people are really happy with Exeter's. Most people are unhappy with this one, which is the Charnley. Just remember that north of the border, north of Birmingham, most people use Charnleys for their cemented. South of Birmingham, most people use Exeter's. So you need to know both when it comes to the exam and how they work. So with the Exeter, it's important to remember it's a taper slip. It moves, it's not bonded to the cement. So it actually, in effect, is an axe that is going into the femur. So what stops the femur splitting or the Exeter just continuing down? The most important concept here is this stuff, the white stuff. It's the cement. The cement imparts viscoelastic properties to the femur. So as you load, you generate what we call hoop stresses. So everyone's happy with hoop stresses. So it's an axial load that's converted into a circumferential load. So the way in my mind that works is it's essentially a balloon. You blow into the balloon and it creates the tension in the rubber, okay? As you push harder or you blow in, or as the rubber stretches more and more, the resistance to blowing in the air becomes harder and harder. Exactly the same way as an exciter engages, it becomes harder and harder as the hoop stresses start to go up. The other bits, the reason the exciter is asked a lot is that the cement will deform over time. We all know that the exciter subsides by a few millimeters over the first year. We call that creep. So again, from a normal day-to-day perspective, what we talk about is a bookshelf. You put a very heavy encyclopedia on there, leave it for a year, and you take the book off. What happens? The shelf has plastically deformed and is left with a constant bow. Similarly, with the cement, it will deform very slightly with continuous impaction of the stem going up and down, and eventually the exciter will settle usually somewhere between 2 and 4 millimeters after the first year. The other viscoelastic property is stress relaxation. So again, I think of this as a rubber band. So if you pull a rubber band as hard as you can out to its limit and hold it there, the most amount of force is required to pull it out in the first place. And then while you hold it, over time, the amount of force required starts to drop off till it plateaus to a certain point. Okay, so the initial stretch creates the most amount of energy, and then as you hold that, over time, it relaxes. So similarly, in an exciter, we talk about stress relaxation of that loading and unloading. When we talk about the Charnley, completely different concept. We're talking here about a composite beam theory, and we're talking about a matte finish to the stem, and therefore there is complete bonding between the metal, the cement, and the bone. So this is what we call a composite beam. It's a mixture of three things. Now with a composite beam, the loading is very different. So it does not load like a exciter. So in a composite beam, the biomechanics of how a beam works is it will always share the load through the most stiffest part of the beam. So if there's a mixture of materials, the stiffest material will always take the most amount of the load. And then as things start to change, then that force will be shared with other bits. So in this scenario, with a Charnley or any composite beam theory, there is so much metal at the top here that actually when you load the hip, the force preferentially goes through the stem rather than through the cement mantle or rather than through the bone. Then as we start to go further down the hip, the metal starts to thin, and therefore force is then slowly starting to be shared with the cement and the bony mantle. So we classically see this in this scenario, which is what we call our stress shielding. So stress shielding is a stiffness phenomenon. At the top, again, we have significant amount of material. So when we load the hip, it preferentially loads through the implant till a point where it comes that the stiffness starts to reduce because there's less material in comparison to there, and the bone starts to share. And you can then see the bone thickening up and taking more of the load. So this is your classic stress shielding, okay? Again, a very common exam question talking about stress shielding, and then what you end up talking about is the composite beam theory, okay? And stress shielding is Wolff's law. Again, basic science. If you don't apply load to a bone, the bone will start to be resorbed, and that's exactly what you see. I won't go through that. So last thing, I've got a few others, but we'll go through this very quickly. The Charnley stem low friction arthroplasty, again, a common question. So in the exam, you will not get asked to draw a free body diagram of the hip. It's too well known, it's too easy, and all the candidates know it's going to come up. What they'll ask you is, here's a Charnley hip, talk me through it, and tell me why a Charnley hip works, and what were Charnley's principles. So we're talking about a low friction arthroplasty. So that's what Charnley called it, and there are specific things that Charnley did to try and reduce what we call the friction to the hip. Now, for me, the friction part is a slight misnomer. Okay, so ignore all these funny symbols, and everyone gets really panicky about this. But what we're looking at is what actually is friction. So friction is a constant, okay? It's a coefficient which is basically developed as soon as you know what the two surfaces are. Your friction is set at that point. And then other things that can affect it are the lubrication within that joint and the sliding speed and the radius, okay? And the load applied. But at no point does it talk about anything else about offset and leg length and those sort of things. So actually, what Charlie was talking about was not actually friction, but what he was trying to do is reduce the amount of joint reaction force across the hip. And by doing that, what he was actually talking about is a low wear arthroplasty. That's what he's trying to create, okay? Now, Charlie always knew that his hip stems would do brilliantly, but the weakness in his construct was always the poly. And he knew that if his poly started to wear out, then he'd get aseptic loosening and all his stems would fall out, and he didn't want that. So he needed a way to minimize the amount of aseptic loosening. So he needed to reduce his joint reaction force. So he medialized the cup. So on a classic Charlie, I'm sorry, I'm going to go back. You see a Mexican hat. So he over medializes to a point he almost breaches the medial wall on purpose. So he knows that he's medialized the cup as much as possible. He does a trochanteric osteotomy, which distalizes and lateralizes the trochanter. And he then uses a small head. Now, all of those have a reason. So again, I've drawn it here. There's your classic free body diagram. But in effect, what I'm going to do is draw it as a seesaw. So you've got your center of rotation. You've got your force of your abductors. You've got your joint reaction force. And you've got your body weight. And you've got your lever arms. So Charlie's concept was to medialize the cup. So the center of rotation goes medial. So therefore, you're lengthening the lever arm for your force of abductors. And in addition, you lateralize or distalize the trochanter. So he's increased that lever arm of the force of the abductors even further. By doing that, the amount that the muscle needs to do to generate the same amount of force goes down. So if that's 5 centimeters versus 10 centimeters, then you have to do far less work with the muscle to generate the same amount of work. And force of abductors, in effect, is proportional to your joint reaction force. Okay, so by reducing your force of your abductors, you have in effect reduced your joint reaction force, and thereby hopefully reduce the amount of wear that's going through your poly. In addition, he talked about the 22 millimeter head. And the reason he did that again was to preferentially go for linear wear versus volumetric wear. So the bigger the head, the more wear you get over a larger surface area, but actually on a physical macroscopic perspective, you don't see a lot of wear, but what you do generate is more volume of poly debris. Whereas with a linear wear, which is a smaller head, sorry, what you're generating is wear which is much more macroscopic. You'll see the head wearing into the poly, but it's only in a smaller area. So there, but actually you're generating much less poly debris, and therefore you're actually getting a lot less aseptic loosening. And I'm going to stop there because I'm going to run out of time otherwise. There are lots of other bits. Any questions?
Joe is thank you very much, Mr. Nawaz. That's an excellent talk. There are a few questions, Joe, if you want to.
Yeah, there are a few questions. Thank you very much first for the brilliant talk. It clarified a lot of things in my mind. First of all, what is the concept of strain distribution in comminuted fracture?
Okay, so essentially, it's a figure in a trauma surgeon's head. Okay,
yeah.
A trauma surgeon, no one can tell you how much strain you need to put across a fracture. That's experience. Okay, so but basically, what you're trying to get is an understanding of how much movement there's going to be across your fracture, and the combination of how many screws you put in, how long the plate is, how much of the plate you're going to make do the work, is all depending on every single individual fracture. And that changes from fracture to fracture to fracture. What most surgeons will say is you need a balanced fixation. So that's number one. So that means you don't put an X-fix on with 5 pins at one end and 1 pin at the bottom end. okay?
Yeah.
And then when you lift that X-fix, it's going to be unbalanced. So similarly, with a bridging plate, you want 8 unicortical screws distally. So that's your classic sort of femoral plate. You don't go bicortical distally. So you'll have 6 to 8 distal screws before your fracture. And then at the top end, if you've got 8 unicortical screws, you want 4 bicortical screws on the other side of the fracture, okay? So you've got 8 cortices either side. That's a balanced fixation. Now the question then is, how much strain do you want across your fracture? So if it's very comminuted, you're going to go for a near-far construct with those screws because you have much more movement at the fracture. Therefore, you don't want as much plate moving because if the fracture is very mobile, then you don't want a long plate taking all that load because it's going to move a lot. So, i.e. the stiffer the construct, i.e. the tighter the fracture, less comminuted the fracture, the further the screws go away. Whereas if you're very comminuted, you then bring the screws further in because you want less movement at the plate. So therefore you're controlling the amount of movement and the strain. Does that kind of make sense?
Yeah, that definitely makes a lot of sense. Thank you very much. And the second question was, an intramedullary nail has short lever arm.
Yes.
So it will be more stable construct, right?
For rotation, yes.
For rotation, yeah, I think the Muhammad meant the torque for the lever arm.
Yeah.
What is the working length in plate fixation with lag screw?
There isn't
That's
one.
from Noman Niazi.
There isn't one. So
yeah, because the lag screw is compression.
If you're genuinely using a lag screw, then a bit like a fibula, your lag screw is doing all the work. So in effect, your plate is a neutralization plate. If you're genuinely lagging that fracture, okay? The screw is doing most of the work, okay? So if you've got a really big, large surface area across the femur, then you're, even with a single lag screw, that's going to have some movement. But what you're trying to do is essentially neutralize the rotation around your lag screw. So if you're genuinely lagging a fracture properly, like on a fibula, perfect anatomical reduction, lagged it into place, and then you put a plate across it, that plate is neutralization, okay? If you're using a lag in a comminuted fracture to bring bits together, then you're mixing concepts. You're trying to get primary bone healing, but then you're using a plate in bridging mode. So you're actually not doing it properly. You're mixing methodologies. So if you're going to put a lag screw across, what you're saying is I can get perfect anatomical reduction and the lag screw is doing all the work and all I want is a plate to neutralize that fracture. The minute you're saying my plate's actually doing some work, you're mixing concepts, okay? And then in that situation, you should be really using it in bridging mode.
I see. So what is the difference between, is there any difference between the working length in a locking and non-locking plates?
Yeah, so the working length of so that's one of the questions, is the working length of a locking plate is from the screw and the screw. It's that, okay? The bit of the plate over the fracture. In a non-locking plate, the working length of the plate is the entirety of the plate because all the plate is moving, okay? Because there is no stiffness and therefore all the screws are moving within the screw holes. Okay, so if you loaded a non-locking plate, every screw head would be taking some pressure. Whereas in a locking concept, the two screws that do all the work is the one closest to the fracture and the one closest to the fracture and the plate in between. That's the working bit. That's the energy part of the plate, okay? Whereas that's the X-fix, yes? It goes through the bone, up the screw, across the plate, back down the screw, and across. So the working length of your plate is that bit. That's the bit the plate's working, and that's those two screws are doing all the work. You're just providing extra stabilization there and there to share some to protect the plate, okay? But actually in a non-locking plate, when you load a comminuted fracture, a bit like that first case that I showed, if you load that plate and weight bear, which bit of the plate is doing all the work? It's all of it. The whole plate's having to work. Whether it's the DCS screw, whether it's the 17 screws at the top, all of them are taking some degree of load and the plate's trying to rip out. Does everyone get that?
Yeah, thank you. So, well, this is a clarification question. Does it mean that the plate bending, the strain at the fracture site, also changes, and this can be reduced by stiffer plates?
Yes, correct. So we didn't want to change the stiffness of the plate because we wanted titanium plates because their Young's modulus is much closer to bone. So it's easier to judge the amount of bend in a plate. So so people looked at making the plates really stiff, and all that happened is that we got more non-unions, okay? Because the plate's so stiff, you have to put screws so far away to generate strain that it didn't work. So then surgeons came up with the idea of something called ASLS screws, which you may have seen, which are wobbly locking screws. So you've got screws, locking screws that you put in, and you fill as many holes as you want, and they sit in a little washer, and it allows them to rock whilst being locked into the plate. So that was a concept that Synthes tried to make to generate the fact that you could get anyone to fix a plate, put as many locking screws as you wanted, but the locking screws were wobbly. It's a very odd concept, but if you look, you can see it's locked into the plate, but actually the screw itself was in a little washer so it could wobble. So it generated movement. So we went the other way and said, you can make it as stiff as you want from the plate perspective, but we'll try and make the screws a bit wobbly, and that generates the strain. Actually, what we found is the easiest way at this point is to get something that's close to bone, and then you play with the screw concepts just to get your strain environment right.
Okay, thank you. Thank you very much. Yeah, that's all the questions, I believe.
Excellent.